Hello, welcome to Wellbeing. I'm Guy Murphy. Today my guest is Brisbane radiographer Callum Howes, and today we'll be talking about X-rays and radiation exposure. So Cal, what got you into radiography?
Well, I kind of knew a reasonably, young age, well, not a young age, but I kind of knew what I wanted to do when I finished school. I knew I wanted to work in health, like in healthcare. I knew I wanted to help people, and originally I had my eyes set on doing occupational therapy, and then I kind of got my results back, and I did kind of slightly better than I thought I would, which kind of allowed me to look into radiography. And yeah, my older brother did radiography for a while. He did the degree, and it wasn't really for him. But he kind of told me a bit about it and kind of sounded appealing to me. And so that kind of got me interested, and it was something a bit different, something about working with radiation and kind of had a bit of mystique to me at the time, I guess. So that's what kind of drew me to it. Yeah, my brother kind of told me it was just mostly about like helping people out and making them feel comfortable and all that sort of stuff. And there was a lot of interactions with the public sort of thing. So that kind of appealed to me. So that's what kind of drew me in.
Awesome. And is it difficult to find a balance between getting the best possible image and minimizing radiation dose?
Yeah, it can be. It kind of really depends, I guess. We have in radiography, we kind of have this principle that we kind of try to follow, which is called the ALARA principle, which is as low as reasonably achievable. So essentially, all that means is you're trying to get a good quality image for the radiologist to be able to make a diagnosis while minimizing the dose as much as possible to the patient. So there's kind of this kind of balance between, sometimes your patient's not the easiest patient to x-ray. They might have an injury that makes their positioning them, getting the right angle and everything kind of difficult to do. But I always found that, like, as long as you're answering the question and you're providing the doctors with the information they need to make the diagnosis, then getting the best possible image isn't really kind of the goal. I mean, it's the goal, but it's not kind of necessary. If a doctor's saying, I want this x-ray because I think this patient's broken their arm, and you take an x-ray of their arm and you can tell that it's broken, you've kind of done your job in a way, You don't have to then take a bunch of other x-rays to get like the perfect angle of it sort of thing. So in that way, what you're trying to do is just answer the clinical question from the doctor, give them that information, and not go crazy trying to get like a perfect picture, if that makes sense.
Yeah, that does make sense. You mentioned it's not of utmost importance to get the best possible image. Does that ever, because you're trying to strike a balance in that regard, do radiographers miss things?
You can. Like, sometimes you'll take an image and, you'll get a patient that comes in and they're difficult to x-ray, they're in a lot of pain, or, you're trying to move their arm into a certain position, or arm, leg, whatever it may be that you're x-raying, and you might not be able to get the best image, and it might not be super clear what you're trying to show because of the limitations of x-rays. So sometimes you'll not be able to get a clear image, and that kind of is a bit of an issue. So sometimes in that regard, you'll have to be like, okay, well, I don't want to keep x-raying this patient because obviously every x-ray you take is another exposure to radiation. So, sometimes you'll take these x-rays and it might be inconclusive for whatever reason. Potentially you might send them back to their bed space. They might get some pain relief, or the doctor might have a chat to them or settle them down in some regard, and you might come back and try again to get a better picture. But usually, if there's any doubt from when you've taken the initial x-ray and you can't get any better pictures, that's when they'll then go on and use a further modality, like a different modality like CT or ultrasound or another imaging technique to try and answer the question.
Right, gotcha. And how do patients generally react when they hear about radiation exposure, and does this affect your interactions with them?
I'd say, for the most part, it doesn't really come up. I think that there's a level of knowledge in the general community, like general public, I guess, about X-ray. I'd say in about 99% of examinations that I'll do, we it doesn't really crop up. Sometimes patients will be curious and ask questions. We have to get informed consent from the patient to be able to do the X-ray. So a lot of the time that'll be like, I'm going to take an X-ray of your arm or whatever body part it may be, and you'll say, is that okay with you, sort of thing. We don't really go into the nitty-gritty of like X-ray exposure for every single case. If a patient asks the question, then we'll explain it to them. But I guess that is when the doctor orders the X-rays, is that level of implied. The doctor will discuss it with the patient and say, look, I'm going to order an X-ray of your arm. And once they get to us, that's kind of an implied kind of risk, I guess. But yeah, it doesn't really come up in conversation. And then, like I said, you kind of get the rare circumstance where the patient's very like hyper fixated upon radiation, and you might kind of go down a bit of a rabbit hole of talking about it. But it doesn't really kind of affect interactions too much, except in those very rare cases where patients kind of hyperfixate, and that can be quite interesting as well. Obviously you just kind of explain it all out and get them comfortable before you proceed. But yeah, I'd say it doesn't really come up too often.
So how do you reassure patients while still being honest about potential harm?
Yeah, I mean, like reassuring patients is part of our job, essentially, in a lot of different ways. We reassure them about the risks of X-rays, reassure them that we're not going to, if they do have a broken arm, we're not going to cause them any undue pain, all that sort of stuff. I feel like, kind of a big part of the job as far as radiography goes is kind of just reassuring people. It can be quite daunting, having an X-ray or having a CT or whatever it might be. It's very not something you do every day, and for some people it can be quite daunting. So I think reassurance is a very big part of our job, making people feel comfortable in an otherwise uncomfortable situation is quite big. So I think that reassuring people about the risks of radiation specifically, like we will just kind of, if they are concerned about that, you just give them all the facts that they need. Like say they're having a chest X-ray, like explain to them, this is a very low dose procedure. It's kind of high yield as far as results go for the amount of radiation you're receiving. For example, like a chest X-ray is equivalent to 3 days of natural background radiation. So in 3 days of living your normal life, you're only adding that amount of radiation on by having a chest X-ray done. So it's almost negligible amount of radiation for the amount of information that the doctors can see from the chest X-ray. So that kind of usually puts most trepidation to rest, which is good.
Yeah, I mean, that's definitely something. I mean, I thought it was significantly higher than that.
Yeah, no, I mean, chest X-rays are pretty much our bread and butter as far as radiography goes. We do a lot of them. It's kind of what people kind of associate with X-ray kind of thing. So these kind of things are always being worked on and iterated on, and then kind of the doses are always coming down. So they are getting lower and lower, which is great. But yeah, I think it does surprise people that it is quite low, which is great. But there's other modalities and procedures that aren't as low. As like CT, for example, is still quite a high dose. So that's something that needs to be kind of worked on, I guess. But it's not really can't really be helped. But it is still a very valuable tool.
Yeah, absolutely. Have you ever felt pressure to perform an X-ray that might not be strictly necessary?
So I guess the process kind of goes where we're on the receiving end of X-ray requests, right? So these requests are filtered through a doctor, and usually these doctors, will be anywhere from interns to consultants who are like your highest qualified doctors. So everyone makes mistakes here and there, and sometimes you might get a request that you think is not super necessary or whatever, but at the end of the day, these doctors have trained for a long time and have put a lot of study in and stuff. If you can, sometimes we will kind of review review X-ray requests. Like if we're not sure, we'll call the doctor and be like, hey, I see that you've requested this X-ray. I'm not really sure, it's going to provide anything useful. And sometimes, doctors, more junior doctors won't have the understanding of the process of X-ray, so they won't really know what goes into getting the picture. So in that regard, sometimes it's like, well, I don't think this X-ray is going to be super necessary. And then, if you have that chat, oftentimes you will get a good response from the doctor. But we kind of do have that kind of dialogue from time to time, where we can kind of give our potential feedback to doctors and kind of say, look, I'm not sure this is going to be fruitful, or for whatever that reason may be. Maybe the patient's too unwell or in too much pain or anything like that. So as far as feeling pressure to do it, I guess, I wouldn't say I felt pressured. I think I just kind of, because I've been doing this for a long time, I have I've got a feeling for when things aren't going to be useful or fruitful, and can kind of inform doctors of that, and sometimes maybe save the patient from getting an unnecessary X-ray.
Right, yeah. I mean, it makes sense that, if it's coming from if it's at the doctor's discretion, then you'd probably, you'd rarely have those sorts of situations.
Yeah, exactly, yeah.
Yeah, but in those rare situations where you have to, weigh up whether the benefit outweighs the risk, how do you handle that?
So for the most part, like you said, given that everything comes at the discretion of doctors, you hope they're kind of dialed in and they know their stuff. And we have our own clinical judgment as well. But if it really does come down to the kind of the wire, and we're like, oh, I'm not sure if this is the right move kind of thing. Like, so for example, like really young patients or pregnant patients, like that, they're kind of at-risk categories, because obviously you don't want to be exposing young kids to radiation if you don't have to, or especially patients who are pregnant, you don't want to be exposing, a fetus to X-rays if you don't have to, kind of thing. So we can then, if we're really unsure that it's the right move, we can defer to our radiologists that we have on site. So they're the doctors who are specialised in looking at and diagnosing from X-rays. So say a request comes in and I'm like, oh, I really don't know whether this is warranted, or this is going to be, the risk is worth it, is worth the benefit kind of thing, then we can defer that to the radiologist. They'll often, call the requesting doctor and review the case with the doctor. So the radiologists have that discussion, and then oftentimes either the radiologist will deem that given the case or given whatever's going on with the patient, it will or will not be necessary. So we've got that kind of third party, if you will, to fall back on if we really feel strongly about it. And usually if we feel strongly about it, usually the radiologist will back us up kind of thing. But it does depend obviously on the context and the patient, the best the outcome for the patient.
You're listening to Wellbeing. My guest today is Brisbane radiographer Callum Howes. And you mentioned kids being a vulnerable population for radiography. Is that because they're smaller, that the same dose is going to affect them more, or is it just because they're sort of, generally vulnerable, or?
It's more just like the time, I guess. The younger you are, the more time you have to be exposed to radiation, and radiation is a cumulative effect, right? So that's why it can be quite difficult to quantify the effect of radiation. Or quantify is probably the wrong word, but it's kind of insidious, I guess, where you don't see it, you can't see the effect immediately. So you take an X-ray and nothing happens to you when you don't feel it. Nothing actually happens to you, but we know from research that over time, repeated exposure to radiation can have negative health effects. So, as a kid, you just have longer to live essentially, and that's longer time for you. We're using radiation more and more in medical imaging. So the younger you are when you start being exposed to radiation, is the more time you have for this cumulative effect to kind of stack up and for it to add up over time, essentially.
Yep. And are there any long-term health concerns commonly discussed among radiographers related to radiation?
Not we know of, I guess. No, I think that we are all very vigilant and all very careful and conscious of exposure to radiation as radiographers. Obviously, we're exposed to it all day, well, not exposed, but we're working around it all day, every day kind of thing. So, we have a lot of these kind of things in place. So, for example, we all wear a radiation badge on it. So every month we'll send our radiation badge off to be monitored to see if we've been exposed knowingly or unknowingly to any additional radiation than what would be normal. So that's a monthly monitoring that we do to make sure that we're not getting any undue exposure. All of our areas that we work in around radiation are lined with lead. So the walls, the glass, everything is lead lined, and X-rays don't penetrate through lead. So we pretty much 95% of the time aren't in the room when we're taking X-rays. And if we are, we'll have a lead gown on with a lead shielding to prevent us from being exposed. And we also get an additional week of leave every year because we are working with radiation, so that's kind of interesting as well. So yeah, all these things are put into place to kind of protect us from this as a hazard, but we're also very careful and very vigilant to make sure that it's not kind of that nothing is that comes with that kind of working around radiation sort of thing.
Right. I'm interested about this badge that you've mentioned. What's that made out of, and how does that pick up radiation and monitor radiation levels?
That's actually a very good question. I've worn one of these things for nearly 10 years now, and I don't actually know what they're made of. That's a great question. All I really know of them, to be perfectly honest with you, is that we usually wear them. We wear them every day. You keep them on a little rack at work. So when you clock in, you kind of just pick it up, pop it onto your uniform, wear it around all day, and then before you go home, you pop it back on the rack. And then at the end of every month, that gets sent away and sent back, and we get a little email that says, this is how much radiation the badge has received, and if there's an outlier, then you have to kind of report that. It's kind of monitored by our radiation safety officers, who are self-appointed people at the hospital, and they monitor everyone's dose and make sure no one's getting any undue radiation. But as for what they're actually made of, that's a very good question, and I should probably do some research into that.
Yeah, some homework for you.
Yeah, thanks, mate.
Oh, good. And so does awareness of radiation risks ever cause you anxiety in your own work?
I mean, risks of radiation on a personal level, like for myself, and I guess the people I work with, no, I guess, just because, as we said, we were very, very conscious and very, very careful around working with radiation. So I'm pretty comfortable in the fact that, I'm working in this environment, but taking all the right precautions. But I guess the radiation risk, as far as it goes when administering it to patients, sometimes I can kind of have a bit of anxiety around that, especially when it comes to imaging like small children. That's one that's really I've never really gotten used to, I guess. It's unfortunate, but that it's a necessary part of the job, and it's a horrible thing to have to do. But for every now and again, a small children come in, they get hurt as well. So like X-rays aren't so bad, obviously, because it's such a small dose. But since I've been working in CT, having to do CT scans on very, very small children, be it a head CT because a small child's fallen off a table or something and bumped their head. That one's a bit stressful. I've gotten a little bit better surrounding that, but I know when I first started doing CT, that kind of stressed me out when I had to do that. Luckily, you don't have to do it very often. These things come up rarely, which is great. But when they do come up, it's kind of one of the harder parts of the job, I would say. So that one kind of stresses me out a little bit from time to time, but I've kind of made my peace with that a little bit these days. But yeah, it did get to me a little bit at the beginning when I was doing CT scans, for sure.
Yeah, no, that does sound a bit tough. I suppose it's it's probably not for no good reason. though, you know what I mean?
Yeah, no, exactly. And that's like like I said before, with like the, running these things by a radiologist, which is like our special X-ray doctors. Any pediatric patient that requires a CT scan goes through a protocoling process where the doctor discusses the case with the radiologist, and the radiologist will say yes or no as far as what they think, if it's necessary or not. So you always have that kind of assurance that the scan is necessary and you're doing the right thing, but at the end of the day, you're still the person that's irradiating the small child. So you are helping the kid, but that does have that kind of effect.
Yeah.
It's hard to shake that one, I guess.
Yeah, for sure. No, I understand that. And do you think advancements in imaging technology are improving well-being by reducing risks?
Yeah, absolutely. I think, the technologies we're using are always being improved upon and iterated on, because, these machines that we're using to administer radiation, obviously they're being sold by private companies. So these companies are always working on their machines to try and make them more efficient, more radiation effective, so that's always something like, that's a big draw to one machine or another. It's like, well, we can produce the same quality image with a lower dose. So, that might make it so one hospital wants to buy this machine or the other. So in that regard, the advancements in technology are actively reducing the radiation that these machines have to give to achieve a good quality image. So that's great. And just generally in that same vein, I guess, like, there's different techniques that are being used that have come about that are more applicable these days. So, like, for example, because the machines are getting the advancements in the technology are improving, and we're able to get these images with lower doses of radiation, you can kind of use these kind of screening tools more readily. So I think a big example at the moment that I'm seeing a lot of is cardiac screening, where patients will have a scan of their heart. It's called a calcium score. So it's usually in your middle to older aged patients where we'll do a reasonably low dose CT scan of the heart. And that just will show very quick scan, very easy to do. It takes like 5 minutes to do. And it shows if the patient has any calcium growing in the main arteries and vessels of the heart. And traditionally, that's a pretty big deal. If you've got a large amount of buildup of calcium in your heart, it can cause a heart attack. So being able to screen for that quite readily while using a reasonably low dose of radiation is amazing, and something that's really come a long way in the last 10 years or so. So that's like one very obvious way that the advancement in technology and therefore the decrease in doses kind of really improved outcomes for people.
Yeah, cool. What changes could further reduce harm while maintaining the benefits of X-rays?
I think that, well, like I said, probably the main thing is just the continued development and iteration on not only the hardware but the software that these machines use. So, like I said before, all these kind of improvements and drops in radiation dose means that you can use these tools like CT a bit more readily, and you're exposing patients to less and less radiation each time, and you're decreasing kind of the burden on the patient each time you use them. So I think probably that's the main one, is just that the iterations on the actual machinery itself to make it more efficient and give less dose while still producing a nice quality image is the biggest thing that's going to increase outcomes and really help, I think.
Has your perspective on radiation risk changed since you've started working in the field?
I think a little bit. I think originally, before I started working, I kind of had a similar take on radiation as the general public, I guess, who kind of didn't understand it very much. But I guess as I've worked with it more and more, I think I've kind of realized that X-rays in just a plain X-ray radiograph is a lot more it's a lot lower dose than what I would have thought, like you said earlier, which is great and obviously very effective. And I think in contrast, I think since doing CT, I've kind of realised that we probably tend to overuse CT a little bit, and that kind of it's a very easy thing to do, to request a CT scan, and the doses are still, they're getting lower, but they are still reasonably high. So I think that that one's definitely a tricky one, and kind of using CT sparingly is something that I kind of like to see a bit more going ahead, I guess.
Right, okay. And just to wrap us up, I mean, we've talked a little bit about, how I'm sure this is probably a common misconception that, I mean, I thought this as well, but, that the radiation dose is actually not that high or the radiation exposure isn't too risky really for each individual scan. But are there any other misconceptions about X-rays and radiography that you've encountered?
I think the biggest one is probably I get called a radiologist a lot. That's a big misconception, I would say, that, radiographers are radiologists, but they're two very different things. So a radiographer is obviously someone who takes the X-rays or the scans, and then a radiologist is the person who has studied to be a doctor and then gone and done more study to interpret X-rays, specifically X-rays and CTs and all the rest of it. So two very different things. I kind of wish I was a radiologist, but I am not. So that's one. And then I guess another misconception, I guess, is what happens to me a lot is a patient will come in for a scan or whatever, and they'll say, "Oh, I need my phone to be out of the room," or whatever. So I think that a lot of people think that X-rays somehow interact with technology in some way, which is just not true. You won't. Your technology doesn't really impact on how the CT scanner or X-ray machine works. So do not stress too much about that. And yeah, they're the two main ones, I would say.
Awesome. Yeah, interesting. Well, that'll just about do us for today, but thank you very much for coming on the show today, Cal. It was great to have you on.
Thanks for having me, man. I appreciate it.
Not a problem. My guest today was radiographer Callum Howes. Thank you for joining us on the show today. Thank you for listening. I'm Guy Murphy, and all of us at Wellbeing wish you well.